Hello, everybody. Thank you for joining me today for a topic that I really enjoy talking about. I've been an RT for about 5 years, and just like a lot of us here, I spent a lot of time in recent years caring for COVID-19 patients in the ICU and in other critical care areas. And I always felt like as we cared for a lot of these patients and as their pulmonary status would continue to decline, to getting intubated, getting put on 100% O2, having to use really high PEEPs of 15 and 20, having to keep them paralyzed and prone just to help with their oxygenation, and having them be on really high pressure requirements, when I felt like there was really nothing else that I could do for them from a respiratory standpoint. I would, as well as a lot of us, I think, just really try to prevent as much as possible some of the really horrific and disfiguring pressure injuries that come from long periods of proning and even sometimes from just extended periods of Cpap or Bipap use. Sometimes it just seemed futile. Just knew that a lot of those people really weren't even going to make it out of the COVID ICU or out of the hospital. But it always did seem like a relative win when we could keep those pressure injuries to a minimum for the patient and sometimes just for their families. So that's where my interest in helping to prevent pressure injuries from our devices stems from. I hope this presentation can help us augment and elevate our care even more for our patient population who may not have COVID-19 anymore, but they are still very critically ill and are really at risk for developing pressure injuries from our respiratory interventions. So just a quick obligatory disclaimer. Obviously, I don't endorse any brands or products in this presentation, and I've not received any compensation by any manufacturers for any devices or products used in this video. Usually, in order for us to intervene in a patient's respiratory care, we are usually having to put something on their face or on their neck or in their mouth, some kind of device that's there out of necessity, but it can also cause injury to the patient's skin over time. And we think about the usual things like face masks, nasal cannulas, BiPAP masks, etc. And so many of our interventions, on the one hand, they help the patient to breathe better, but they do come at a cost. Obviously, we were concerned about pressure injuries from our devices before COVID, but we really got a lot of exposure to what those injuries can look like in their extremes. So we would have these severely medically compromised patients that were needing long-term interventions. And so while some of the outcomes on patients' skin were just unavoidable, maybe more so than ever, we were just really engaged in skin assessment on the patient's face and head from our devices, particularly when they were being proned. And so that being said, as we trend back into what is the new normal, it would be great if we can just keep some of that momentum of skin assessment and early interventions going to help prevent skin breakdown for our patients. Because truly prevention of a pressure injury in the first place is the best strategy. Pressure injuries are managed in tandem with wound care RNs and physicians, and the whole process is very expensive, approximately $75,000 per pressure injury, according to the NPIAP, which we'll talk about here in a minute. The way that we're going to do this is we'll talk about our connection to pressure injuries, followed by a pretty brief review of the anatomy and physiology of the skin. And then I'd like to go over the types of pressure injuries and skin damage that can occur in a hospital setting, but specifically in an acute care setting. Wound care is its own specialty, and it has its own department here at our hospital. And so as we go through this information about pressure injuries and a lot of the pictures come directly from our wound care department. The wound care team here at JPS, it also offers additional training and resources through a group called the SWAT team. And you don't have to be an RN to be part of the SWAT team. So I signed up for it, and they provide a ton of education. And we look at different patients, and we learn about like different pressure injury types and different prevention strategies. And so a lot of this presentation reflects things that I learned from the wound care team. Next, we'll go over the Braden scoring system and how it can give you some insight into the potential for skin breakdown for different kinds of patients. And then we'll talk about strategies for prevention. And some of these things may be things you already do, but I hope there can be some new things that you can take away from this and include into your practice. And then finally, we'll just go over a few real life scenarios. Pressure injuries affect 2.5 million patients per year in the US alone. And that information comes from the NPIAP, which stands for the National Pressure Injury Advisory Panel, which is an independent nonprofit organization that puts out guidelines for pressure injury prevention and also education and resources pertaining to the prevention and management of pressure injuries. Besides the cost to the patient in terms of pain and long-lasting damage and some of these disfiguring wounds, pressure injuries are incredibly costly to healthcare facilities. The cost of individual patient care ranges from almost $21,000 to almost $152,000 per pressure injury. And this estimate comes from a study back in 2019 from the Agency for Healthcare Research and Quality, which is part of the U.S. Department of Health and Human Services. The costs come from not only the supplies, but also from the expertise needed to treat those wounds. And a lot of these wounds take a really long time to heal, and so they necessitate long-term care. So what is a pressure injury? A pressure injury would be considered skin breakdown, and it's considered hospital acquired if it happens after 24 hours of admission to the hospital or the facility. But it's not necessarily considered that if they come in with an existing pressure injury and it happens to get worse, then it's not considered hospital acquired usually. So if the pressure injury is hospital acquired, the hospital would have to pay for the treatment out of pocket. And in 2016, according to an article published in the International Wound Journal, pressure injuries cost hospitals an estimated $26.8 billion. And this graph shows the percentage of device-related, call them HAPIs, the hospital-acquired pressure injuries by location. And you can see that a huge percentage of device-related pressure injuries are located on the head or the face or the neck. And that might make you start to feel a little uncomfortable just thinking about all the devices that we have to use there. And so basically all of our interventions are things that we have to strap on a patient's head or wrap around their neck or push down on their faces. And everything that we do to intervene is something that has to come into contact with the patient's skin, particularly on their faces and on their heads. Not everyone who has to have these interventions goes on to get pressure injuries. So why do some people get them and others do not? Well, there's a huge list of risk factors for pressure injuries, and I had this huge list and I tried to sort through it and organize it a little bit differently. So here it is. This first list represents patients specifically in an acute care setting like the ICU. They are primarily bedbound, they are dependent on staff for repositioning, they are awfully deeply sedated or paralyzed, and they often can't tell you that they are, for example, laying on their arm or that there's a cord that's underneath them. They just can't communicate at all. And they're sometimes on medications like vasopressors that cause vasoconstriction in order to improve their mean arterial pressure, their MAP, but can come at the expense of perfusion to tissues and to skin. And also, many patients are unable to clean themselves. So unless they have like a Foley or a rectal pouch, then moisture as far as incontinence is always going to be an issue. And in addition, diaphoresis, sweating, the skin staying wet, that puts them at more risk for skin breakdown. And we'll talk a little bit more about that here in a minute. And so this list here is by no means exhaustive, but it's a start. Other risk factors would include things like diabetes that can cause nerve damage so that the patient can't really feel the pain that would typically cause you to readjust your body to improve blood flow. Strokes, which can cause weakness and oftentimes immobility, and that's the same thing with like multiple sclerosis. cardiovascular disease or peripheral vascular disease where blood flow is compromised to the tissues. Obesity, typically just because of poor nutrition status and then the physical limitations of actually caring for themselves, and also the accumulation of moisture in skin folds, as well as spinal cord injuries, which is similar to the damage in diabetes where that signal for pain never makes it to the brain. So the patient doesn't feel that pain caused by ischemia to the area. And then also smoking, which reduces blood flow to the skin, and it can actually contribute to delayed wound healing. And then as far as what you would see typically as far as demographics, these would be a lot of older patients who are more at risk, especially if they can't get up and move. The longer that they spend in a hospital setting laying in bed, the more at risk they are of developing a pressure injury. And then you have patients who simply refuse to be moved to allow staff to care for their skin properly. And that can easily lead to them developing skin breakdown. And then there's nutrition, and nutrition is super important in preventing skin breakdown. And when the body is not getting nourished properly, it can lead to an increased risk of skin breakdown and pressure injuries. So let's talk about skin. Histology, which is just the different layers that make up the skin, they vary by where you are in the body. So for example, like mucous membranes have a completely different histology than the skin on your hand or your arm. And so we'll just keep this really simple. So we'll just talk very generally. We'll start with the epidermis, which is the top outermost layer. And it's the first line defense for protection against foreign invaders like bacteria. And it's partly responsible for heat regulation and for the prevention of moisture loss. It's made up of 4 different layers: the stratum corneum, the stratum granulosum, and stratum spinosum, as well as the stratum basale. And most of those layers consist of just dead or dying keratinocytes, which produce keratin. And that's that protein that makes up skin and nails and hair. And it forms like a protective barrier against elements like UV rays, heat, water loss, and bacteria. And although keratinocytes are constantly being pushed up to the surface and drying and flattening out, and eventually sloughing off, the entire turnover for that layer can be upwards of a month and a half for an older adult. So the stratum spinosum, that's that third layer. It's actually the thickest layer. It consists of these basal cells that have matured into keratinocytes. And interestingly, they house these types of cells called Langerhans cells that will attach to foreign substances and then will alert the immune system to a foreign invader. And they also have cytokines, which are these like proteins that act as messengers between cells. And that's really important in launching an inflammatory response. And then finally, the stratum basale, which is the deepest layer of the epidermis. And this layer houses melanocytes, which are responsible for making melanin. Next up is the dermis, which is the thickest layer of skin. And its function is to produce sweat, feeling different sensations. It houses sebaceous glands like oil glands and hair follicles, and it also contains a lot of water. So you have that top layer, which is the papillary dermis, very thin, made out of like collagen fibers, has like fat cells, and it's got blood vessels just all throughout it and capillaries, as well as nerve fibers. And it also has cells called phagocytes, which eat bacteria and other harmful substances. And then underneath that is the reticular dermis, which is made out of elastin and collagen fibers. And its function is it kind of helps you to be able to stretch. And then finally, the hypodermis, or the subcutaneous layer, which helps to insulate and protect the body. It stores energy, and it's important for temperature regulation. And it's where the skin attaches to the bone or to the muscle. And so this layer stores fat and adipose tissue, which kind of acts as shock absorbers and insulation. And it contains a lot of the same things: collagen fibers, connective tissue, nerves, blood vessels, and macrophages, which again play this really important part in the immune system and also in repairing damaged tissue. And pressure injuries that have broken down the skin's natural barrier are a huge source of infection, and it can cause the patients to have a significant amount of pain as well as prolong their hospital stay. And so it's important that we understand that sometimes we are incidentally contributing to the disruption of a very intricate and complex system that is designed to protect and stabilize the body. And so when a patient does have skin breakdown or pressure injuries, they're at risk for further deterioration and for getting sicker. I won't go too much into this, but basically the lymphatic capillaries and the blood vessels in the body will work together. Their main function is, at least the lymphatic capillaries, is to help remove waste and fluid. And those numbers at the top, those are the minimal pressure that it takes to collapse the blood vessels, which is called the capillary closing pressure. And so if that occlusion lasts, then it can cause ischemia. The blood vessels and the lymph channels get occluded, and that means you'll get less oxygen to your tissues, which means the cells are going to have to start changing over to anaerobic metabolism, which means you're going to have this buildup of waste products, which will eventually lower your pH, and eventually the cells will just die. So let's talk about ischemia. So for us, like, ischemia should cause pain and it should cause discomfort. And that's because your body will send a message to the sensory cortex of your brain to coordinate a position change to restore blood flow to an ischemic area. One example is to sit on your hands. Just sit right on them, on both of them. And then after a few minutes, with that direct pressure from the weight of your body, you will start to feel a little bit of discomfort and pain in your hands. And almost without even realizing you're doing it, you will start to rock back and forth on your hands to relieve some of that pressure and restore blood flow. In patients who have lost this sort of innate pressure injury prevention system are at very high risk, especially if they can't feel or they can't move, and they're completely dependent on staff for repositioning. So there are two different kinds of injuries that are not technically considered pressure injuries. They're medical adhesive related skin injury called MARSI, and also moisture associated skin damage, MASD. And so this picture here on the right, these would be the areas of the body where you're most likely to see pressure injuries because they're over bony prominences. I'm sure we all know, but we do not stage pressure injuries. We do not look at what is obviously skin breakdown on a patient and say, well, that's obviously stage 1 or stage 3. We can say it looks like it, but only a wound care RN or a physician can document the stage of a pressure injury or call it one stage versus another. What does a stage 1 pressure injury look like? In this one, you have this reddening of the skin. The skin is intact. It has something called non-blanchable erythema. And what that means is when pressure is applied to the skin and then released, the skin doesn't go back to its original shade. That picture up there of a tomato is kind of what it would look like. It's red. If you push down on it and then let go, it would stay red. And these can be anywhere. The top layer of skin is intact, but the skin is reddened and it just stays that way when you press down on it and release. So that's kind of what it looks like. This is another example. This is a kid, and I think that they said that this was from a Bipap mask or from a bubble Cpap. So this was identified by a wound care nurse as a stage 1 pressure injury, but that reddened area probably would not blanch or turn white if you were to press down on it. Next is stage 2, and that is defined as partial thickness loss. What that means is basically the epidermal layer is gone, or the epidermal and the dermal layer is gone. And so it's kind of like a potato that had that top layer peeled off. Here are some examples of stage 2 pressure injuries. One is from something that they were wearing on their nose. I'm not really sure. And the second one supposedly caused by a pulse ox probe. And the next is stage 3. That would be a full thickness loss of skin. And full thickness means that it extends beyond the dermis into the subcutaneous layer or beyond. They kind of liken it to taking a big bite out of an apple, if you can see those deeper structures. And we won't talk about this very much at all, but that picture there on the bottom, the epibowl, it's kind of like when the skin is trying to heal and it's trying to reach across and grow back over the wound, but it can't because there's delayed wound healing going on. That's very typical of stage 3 pressure injuries. And then finally, stage 4, that would be full thickness skin and tissue loss with exposed fascia, muscle, tendon, ligament, cartilage, or bone. And so stage 4 is just when the wound goes so deep that it exposes the base structure. So it's like taking a bite out of a peach and then seeing the pit in the middle. And a lot of times it's covered with slough or with eschar. So slough is this example here on the left, that left picture. It's made out of fibrin and white blood cells and bacteria and debris. And it's just part of the body's inflammatory process. And then eschar could even be like the darker spots in that picture, which that would be more necrotic granulation tissue. And so with stage 4 pressure injuries, the depth kind of varies by location. So areas like the ear and the nose are particularly vulnerable to this really fast progression of a pressure injury from a 1 or a 2 to a 4, because as soon as you get to cartilage or the bone in the upper part of the nose, you're at a stage 4 pressure injury. And so it's just much easier for it to happen on the face than it is in other areas of the body. And stage 3 and stage 4 pressure injuries are the most costly, and they're also not reimbursed by Medicare and Medicaid because they're considered never events, meaning that a patient should never come into the hospital without a pressure injury and then go on to acquire a stage 3 or a stage 4 pressure injury. So if a patient gets these at a hospital or at a facility, then chances are the hospital is going to pay for all of it. This is another type of pressure injury just called an unstageable pressure injury. And that is when the wound care nurse wouldn't be able to see the base of the wound. So they can't really tell how deep it goes. And so it's just called unstageable. And a lot of times they can't see it because it's covered with either that slough, which is the picture on the left, or eschar, which is the picture on the right, that necrotic tissue. And then you have something called deep tissue pressure injuries, the DTPI. And that is when you can have intact or non-intact skin that have this area of persistent, non-blanchable, deep red or kind of purple discoloration. And sometimes you can see a blister, but not always. Those are the results of very intense or like prolonged pressure and shear forces at the bone and the muscle interface. And that pressure will actually directly deform the cells and will cause cellular damage that starts really fast. Then something that can happen is you have this area of cell death, and then when blood flow is restored, it can actually cause more damage, which is known as reperfusion injury. Then there is the mucosal membrane pressure injuries. The pressure injury classification system doesn't really stage mucosal pressure injuries the same just because the histology, like the layers of skin, are different between the mucous membrane and other parts of the skin of the body. The mucous membrane could include inside of your nose, inside of your mouth, the tongue, the inside of your lip. So the non-blanchable erythema that you see in stage 1 pressure injuries, you can't really see that same thing in mucosa. And in mucosal injuries, what looks like fluff, it's actually just these soft kind of blood clots. Usually injuries here are caused by medical devices, but they may not always be respiratory devices. They could be feeding tubes, Dopphoff tubes, things like that. And then these are just a couple more examples. The injury to the tongue on the left was caused by an ET tube. You can see the picture on the right. That's an ETAD. It's also called an anchor fast. That is securing an ET tube with a bite block in place. That's that kind of orange semicircle right there. Moisture-associated skin damage, or MASD. From a nursing perspective, this could include ostomies, wound exudate, skin folds, incontinence. Respiratory-related could include moisture underneath the device, such as a trach tie or an ETAD tie, where sweat and saliva and mucus is trapped on the skin for a prolonged period of time. Or trach patients who are on a trach collar and they're able to cough up their secretions, but maybe they aren't able to clean around their trach site themselves. So those secretions just sit there until someone notices it and wipes it off for them. And then even think about the CPT vests that we use. I know there's a lot of different kinds of CPT vests out there. So the ones that I'm referring to, like those long kind of pads that wrap around the patient's upper torso, and it's secured with Velcro. And then it connects over to the CPT machine itself with a couple of hoses. I'm sure most therapists are familiar with that kind, but they're oftentimes placed underneath the patient. And sometimes we leave them there in between treatments. And moisture from sweat or from other bodily fluids might end up just trapped there against their skin, which could lead to maceration of the skin in that area. Also, those CPT vests have that Velcro on one side, and so you have to be really careful about manipulating the pad underneath the patient so that abrasive side of the Velcro doesn't scrape up against the patient's skin and damage it, especially if it's already really moist and macerated. That picture on the left is from a clip pulse ox probe, and the picture right there in the middle is from an oxygen mask strap. One study in 2010 showed that 35% of the medical device-related pressure injuries were stage 1, 32% were stage 2, and only 3% were stage 3. But 24% were stage 4. So you can progress really quickly on the face from a stage 1 or a stage 2 to a stage 4, just because of the thinner layer of skin. Then we have this concept wound care is always talking about, which is maceration and then desiccation. Macerated skin, which is just skin that is very, very moist, is a weak barrier. At the same time, though, you want to maintain a slightly moist wound surface because it will help to facilitate cell migration, but it also prevents cellular apoptosis. And they always say if you have a dry cell, then it is a dead cell. Moisture-associated skin damage, or MASD. From a nursing perspective, this could include ostomies, wound exudate, skin folds, incontinence. Respiratory related could include moisture underneath the device, such as a trach tie or an ETAD tie, where sweat and saliva and mucus is trapped on the skin for a prolonged period of time. Or trach patients who are on a trach collar and they're able to cough up their secretions, but maybe they aren't able to clean around their trach site themselves. So those secretions just sit there until someone notices it and wipes it off for them. And then even think about the CPT vests that we use. I know there's a lot of different kinds of CPT vests out there. So the ones that I'm referring to, like those long kind of pads that wrap around the patient's upper torso, and it's secured with Velcro. And then it connects over to the CPT machine itself with a couple of hoses. I'm sure most therapists are familiar with that kind, but they're oftentimes placed underneath the patient, and sometimes we leave them there in between treatments. And moisture from sweat or from other bodily fluids might end up just trapped there against their skin, which could lead to maceration of the skin in that area. Also, those CPT vests have that Velcro on one side, and so you have to be really careful about manipulating the pad underneath the patient so that abrasive side of the Velcro doesn't scrape up against the patient's skin and damage it, especially if it's already really moist and macerated. Medical adhesive related skin injuries, or MARSI. MARSIs are not considered pressure injuries, but they do come from the mechanical trauma associated with medical adhesives. One example for us might be the cheek pads from the ETAD or from an anchor fast. If the patient has any kind of an allergy to the dressing, or if the patient's skin has remained really wet and moist, then that tissue can become macerated and be more prone to tearing from a medical device with an adhesive. Let's move on to the Braden Score. The Braden Score is a standardized tool that was developed by Nancy Braden and Barbara Bergstrom in 1987. Some sources said 1986, so it's one of those, which helps to predict the risk of a patient getting a hospital or facility-acquired pressure injury. The lower your score, the more at risk the patient is for getting a pressure injury. And it's based on an assessment of sensory perception, moisture, activity, mobility, nutrition, and friction and shear forces. And this is, at least at our hospital, it's assessed and documented by nursing. And this is kind of what it looks like. So you would score them based on what you are seeing them do or how you're seeing them perform on your shift. The first is sensory perception, so to be able to respond meaningfully to pressure-related discomfort. Things that we talked about in the beginning to consider: patients who have diabetes, who have that neuropathy, or patients who are paralyzed or who have spinal cord injuries where that message isn't making it to the brain that there is pain and that they need to move. Or if they have some kind of dementia or cognitive impairment and they are unable to recognize the source of that pain or that they should move. And then there's moisture, the degree to which the skin is exposed to moisture. An increased level of moisture puts the patient at risk for developing a pressure injury, which is kind of what we're talking about with maceration. This is typically associated with incontinence, but it could also be caused by sweating, by someone who is very overweight, who has those skin folds, but also from moisture from the peristoma around a trach, especially if it has a lot of secretions coming out of the trach. Then also just around very highly exudative or transudative wounds. And then also from a nursing standpoint, that could include ostomies that are leaking, or even edema on the legs, where it's called weeping leg edema. You see it a lot in heart failure patients. Then activities. To what degree is that patient physically active? And it's not about what they can do, it's about what they are doing. So someone might be able to get up and walk around the room, but if they don't want to, or they're not reminded to, or whatever, then you have to score them as though they're not getting up. And then nutrition. This would be the usual food intake pattern. It can be scored accordingly for a patient who takes food by mouth, or who needs a NG or an OG or a PEG tube, or even if they're receiving nutrition by IV or TPN. And so one of the easiest ways for us, since we are not nutritionists, one of the easiest ways that we can look at a patient's nutritional status is to go look at the notes that are being put in by nutrition services. And then friction and shear. The difference between friction and shear is that friction is when the skin is rubbed against another object, but shear is when forces are moving in opposite directions, but there's another force at play, like gravity. An example of a friction injury would be like a part of the body just rubbing against the sheets or a bed rail, something like that. And then an example of shear would be when a patient slides down in bed, and let's say that they're kind of sweaty, so their skin kind of sticks to the sheet. And so as they slide down, their outer layer of skin stays in that one spot, but the deeper layers of tissue on the inside that are attached to the bone are moving down. And so that movement is what can cause a shearing pressure injury. This is an example of someone who scored really low on the Braden scale. He's a 57-year-old with a history of diabetes, morbidly obese, and he's intubated, paralyzed, sedated, prone, and is on pressors. So for him, his Braden score is an 8. He's extremely at risk of getting a pressure injury. Here are some of the tools that you might have at your disposal at your facility. The first is hydrocolloid dressings. I think at our facility, the brand name is Duoderm, but there's other ones as well. And this is good for lower exudate, non-infected, shallow wounds. And you can also cut it into strips and place on top of a patient's ears where the nasal cannula or where the airvo strap might have prolonged contact, or that friction that we kind of talked about earlier. It can also be used to prevent skin maceration. So something that our wound care team recommended is that when you have really goopy trach, where secretions are just coming out and just pooling on their chest, you can put a hydrocolloid dressing just below that trach site so that when they cough up secretions, it stays on the dressing and it can just be wiped away and it protects that skin underneath. And as far as dressing changes, I think the Duoderm manufacturer says every 3 to 4 days, but obviously you should follow whatever your facility guidelines are. And then there's foams. Nursing uses foams all the time. You'll see them place these large, almost heart-shaped foams over the patient's lower back, as well as other bony prominences to protect and cushion that area. And for respiratory, foams could be really useful behind a trach tie around the neck, or behind an endotracheal tube holder on the patient's neck, or even when somebody is in a seat collar and their ears are just constantly rubbing up against the side of the seat collar. The foams can help to keep the ears from getting skin breakdown and causing pain. And then we have barrier wipes, and anywhere you put it, it will create this thin barrier. Some brand names are All Care and SurePrep. I think I've seen those at our hospital. And you can also use it to loosen something that is sticky, like a medical adhesive. So secretions that are stuck to a trach tie, or the face pads specifically on an ETAD or on an anchor fast. If you use those when you're removing the ETAD, it can help to prevent MRSA, or when you're removing pieces of Duoderm. Then we also have ear cushions. Some types of nasal cannulas already have the ear cushions built in, but ours don't at the hospital. So we have these little ear foams, but they have a slit down the side so they can slide off. So to keep them on, you can just add like a little piece of silk tape or transport tape to keep it secure on the cannula tubing. So let's talk about strategies. One of the biggest strategies is early recognition of pressure injury risk. So assess your patient's skin. Notice areas where our devices are coming into direct contact with the skin surface, particularly when a patient is already more at risk for developing pressure injuries, which you might see in their Braden score. Consider ways to prevent pressure injuries for your patient. Consider ways to redistribute pressure and cushion or manipulate a respiratory device to avoid that continual direct pressure. If your Cpap or your Bipap mask is starting to break down the bridge of the nose, then consider switching to a different interface. There are Bipap masks that they make that can go underneath the nose instead of on top. And other strategies, regularly repositioning the device. I know at our hospital, nursing is responsible for moving the ET tube and the anchor fast from side to side, but that may not be the same at your facility. If you suspect that your patient will need to be on Cpap or Bipap for a while, be proactive about skin protection. Consider early prophylactic use of something like a foam or a hydrocolloid. We have a gel that's called Curaplex here that goes over the nose and over the cheek, and try to prevent further infection or injuries. If a patient has breakdown in an area, try to find a way to avoid placing anything else on that area so that it can heal. And then also regular dressing changes. So for example, good and consistent trach care that keeps the trach site clean and dry. And then timely removal of sutures. At our hospital, we wait about 7 days before removing the sutures around the trach faceplate. But there are definitely times where we remove it sooner because the stitches are pulling on the skin and they're causing something called a stitch abscess. And I'll talk just a little bit more about that later. And then early and regular weaning trials. And this goes for anything, weaning your O2 off patients to see if they can maintain their SATs, trialing patients off of Bipap or Cpap as soon as you can, and then communication with the oncoming shift about existing pressure injuries related to a respiratory device. Like, I noticed that on the top part of the patient's ears, they were starting to look a little bit red. So I went ahead and I put some hydrocolloid dressing on that area, or I added some soft foams to the cannula to help cushion it. And just relaying that information to the oncoming shift to bring it to their attention so that they are also reminded to be mindful of it themselves. And then communication with the patient's physician. We all know that we can be a huge advocate for our patients. And so if you see something, say something. Bring it to the attention of the nurse, or better yet, the physician, so that they can get wound care involved if needed. If you can catch skin breakdown early on, then you may be able to keep it from getting worse and even give it a chance to heal. Another strategy is trying to avoid cinching the O2 tubing. And it happens a lot, especially when nursing is trying to keep that O2 tubing on the patient's face and in their nares. But if it's not readjusted or loosened, then it can leave marks on the patient's face. And that comes from the pressure that's just being exerted directly on the skin by the cannula. At our facility, we have an O2 protocol, which states that we should wean a patient's supplemental O2 to achieve an SpO2 of greater than or equal to 88%. So the sooner they can be weaned off the O2, the sooner the cannula drops out of the picture as a source of a pressure injury potential. Like I was talking about earlier, there's newer Bipap mask designs that avoid the bridge of the nose altogether. They sit underneath the nose and they go over the mouth as well. And then, like I also said, there are these gels, and one brand is called Curaplex, that can be placed over the bridge of the nose and on the cheeks that can help to buffer the skin from the Bipap mask. And then for tracheostomies, you want to regularly assess the area under the trach flange and the faceplate, as well as around the peristoma, and then also under the straps or the ties and under their chin. Advocate for your patient. If you notice that the trach sutures are pulling a lot on the skin of the neck, ask the physician about whether or not they can be taken out a few days early. If those stitches continue to pull really hard on the skin, it can lead to a stitch abscess. Then after the sutures are removed, place some kind of barrier between the patient's skin and the trach faceplate. And we may not think about pulse ox probes as much, but they can be used on the ears or the fingers. I've even seen different kinds of probes be clipped onto the patient's nose. And the light from the pulse ox can eventually cause burns. So make sure that we're collaborating with nursing to make sure that the probe is being moved regularly, and never put a probe back on an area that already has skin breakdown, because you'll just be causing further injury. And sometimes people will use the pulse ox probes in a way that are not necessarily in accordance with the manufacturer instructions. Like, we will use neonate little sensor probes and we'll put them on the earlobe. But what will happen is they'll get wrapped around the earlobe really tightly, which will just end up cutting off blood flow and will lead to swelling and then skin breakdown. So you have to be mindful of that. And then when proning, you want to try to protect the lips from touching the endotracheal tube or whatever securement device you're using as much as possible. And I'm sure during COVID, we all got really good at applying foams and hydrocolloid dressings to areas of the face that we wanted to keep from breaking down. But ears are another concern during proning, especially when the patient is not really tolerating turns, so they're having to stay in one position for a long period of time. That skin breakdown on the pinna of the ear, like we said earlier, it can quickly evolve into like a stage 4 injury, just because by definition, stage 4 is the exposure of that base layer, which for the ear is cartilage. Just one trick that we did during COVID, we would try to keep the ear that was down closest to the bed, we would try to keep it sort of suspended by rolling a soft sheet or blanket and placing it underneath the patient's head. And then we had a kind of malleable pillow that we would push underneath the patient's chest. So we would try to create this space for the ear to hang without really coming into contact with something. Let's go over scenarios real fast. We're about to wrap up here. Scenario 1, your patient is 4 days post-op trach with sutures still in place. There appears to be swelling and ulceration around 2 of the 4 sutures. What can you do to address skin breakdown in this area? For that, you would talk to the physician about removing the 2 stitches that are pulling and causing ulceration, and then clean the area with sterile water and gauze, or whatever you use at your facility. I know it varies. Then you notice the peristoma appears to have skin breakdown and ulceration around the trach faceplate. What can you do to address skin breakdown in this area? Well, you can clean the area again with sterile water and gauze and apply a Cpap dressing underneath the flange, and then contact a physician about placing a wound care console. Obviously, we would never stick anything behind that faceplate. So if there were secretions there, we would never take something like a Yonkauer or some kind of a suction device and suction back around that area, because we would be reintroducing more bacteria to a site that already has breakdown around it. Scenario 2, your patient's saturation is 96% on 2 liters nasal cannula. You notice redness behind his ear and that his cannula has been secured tightly so that it won't come out of his nose. What should you do first? Well, first, you should try to wean off your oxygen. If he maintains his sats without any oxygen, then he doesn't need it. And obviously, you would follow your institution's guidelines on weaning that oxygen. So for our facility, if the patient were to desat below 88%, then we would have to put the oxygen back on and maybe consider putting that duoderm or hydrocolloid dressing around the ears or using earphones on the cannula. Scenario 3, you notice that your trach patient has skin breakdown around the peristoma, and there are stay sutures in place, which are the ones that are kind of inside of that wound. What can you do? Well, contact the physician about wound care consult and check to see if wound care is already following the patient and follow their guidelines. The faceplate needs to stop coming into contact and rubbing against the wound directly. And then follow your institution's guides on how to clean the peristoma. It might be the institution's preference for normal saline or sterile water, or even an antiseptic skin prep. Scenario 4, you notice that your trach patient has a copious amount of thick yellow secretions, and you notice secretions pooling on his chest wall with each assessment. What could you do to prevent maceration of the peristoma? Well, you would clean and dry the area with sterile water and gauze, and then place duoderm or some other hydrocolloid dressing over the skin inferior to the trach site. And that way secretions can be wiped off the duoderm pad directly. If you would like to do any more of your own research, the NPIAP, their website has a lot of resources where you can read more about pressure injuries and prevention.